YouTube is live now. Purple, you can go ahead.
Mm. Good evening to my respected teacher, seniors, my juniors, and my friends. Today, the whole of Assam is mourning the loss of a great personality, former Chief Minister's late Mr. Tarun Gogoi. We in Nabai also pray to God, his soul rest in eternal peace. So we in Nabai are very happy to carry out a excellent academic activities in last couple of months in this COVID-19 pandemic period. I personally feel the almost all the classroom were very successful, and for this I want to give the thanks to all the members of Nevai and academic council's members for their suggestion and advice. And especially, I want to give the thanks to our three key persons behind the success of this webinar: Dr. F.S. Hakim, Pujia Baido, Dr. Anjana, and Biswajit Gogoi. So for their untiring effort and continuous initiations to make these all webinar successful. Again, thanks to them. So today also we are going to uh, discuss a important subject that is endoscopic tympanoplasty. So this is the subject. Previously, it was not popular, but now becoming it is popular, and many of our budding NT specialists use this procedure. So for the discussions of this subject, speaker is Mr. Dr. Jagori, and moderator is Dr. Anupam Hazarika. So just small introductions about the Anupam. The Dr. Anupam did MS in 2007 from Guwahati Medical College. After that, he worked as a faculty in Jorat Medical College and Assam Medical College till 2017. He is having primary affinity for otology with special interest in endoscopic approach. He designed Indian patent granted for self-designated design endo holder for dual hand technique of ESS, and developer of concept of functional endoscopic middle ear cleft surgery. He awarded winner in ISOCON and AOICON for the novel concept. Presently, he is consultant of Advanced ENT and Head and Neck Clinic at Jorhat. Now, may I request Dr. Anupam Hazarika, please moderate the sessions and the brief introductions and about Dr. Jagori. Please, Anupam.
Thank you, Apurvada. A very good evening to all of you. So, as has already been given an introduction as to what topic we are going to discuss today, before at the outset, I would like to thank NEBOI for their untiring effort towards conducting the academics on a regular basis to do the brushing of our academic activities so that new things are being learned each and every in every way. And today we are going to discuss on a topic, endoscopic tympanoplasty. So as we know, since there has been a lot of debates in the last 2 decades, and I would like to start this whole thing as with the opening remark that we are surgeons of the year, as has already been said. Endoscope in ear surgery has added new meaning from being an adjunct initially to becoming a full-blown technique. So technology, as we see, is meant to be exploited provided conditions are favorable both and beneficial both at the receiving as well as at the giving ends. So despite the continuous efforts by the stalwarts in this field and its slow acceptance, but the last decade has witnessed tremendous development both in terms of technique as well as the associated technology, giving the otologist an opportunity to understand the physiology and ways to deal with the pathophysiology of the ear disease with added confidence and of tissue handling and disease clearance, and also decrease associated morbidity with the procedures. And endoscopic ear surgery today stands in the horizon of acceptance after having passed through an era of ridicule and vehement opposition. So we are grateful that even ISOCON has accepted endoscopic ear surgery as an upcoming technology and technique for the betterment of the otologic procedures. So today we have with us Dr. Jego Ori. He is a MS TNT gold medalist and is presently assistant professor of TRIMS, Nahalagun, Arunachal Pradesh. He is trained at Royal Pearl Hospital, Trichy, and has 13 publications. He has been awarded the Best Outgoing Postgraduate of RIMS in 2012, and he has commendation certificate from the government of Arunachal Pradesh for outstanding medical officer, and he's with the IMA Tamrapatra Award. He is the award winner of SN Sharma Award, Best PG Award paper. He has been awarded Best Postgraduate Paper in RIMS, and at present he is the Honorary Secretary of Indian Medical Association branch of Arunachal State branch since last 5 years. And the best part and is about Jagor is that he himself has single-handedly conducted 12 times Loving Otology workshop. That is a informal forum we have of the All India body who are all comprises of people having obsession for otology. So I congratulate Jego on this part. So Jego, please, you start your presentation.
Thank you, sir. Good evening, everyone. Respected teachers, today's moderator, Dr. Anupam Hazarika, sir. From the state of Arunachal Pradesh, on behalf, I would like to share the grief of the people of Assam for the loss of a great personality today. And this is an opportunity for me to present my paper. Let me just share the slide. Can you hear me now?
Yes, you are audible.
Let me just, Is it okay, sir?
Yeah, it's your slides.
It's
Sir.
okay.
Okay.
Yes, it's coming.
Yeah, you can proceed.
Okay. So I am working as assistant professor, Department of ENT, New Medical College of our state. So after post-graduation, usually being a post-graduation, we used to have a confusion whether we should go for microscopic or endoscopic ear surgery. Then the technique of ear surgery expanding rapidly. The endoscopic ear surgeries allows a minimally invasive approach. Endoscopic ear surgery is challenging, but there are several techniques that allows the successful outcome. The rationale of endoscopic ear surgery is the chronic ear problem is because of the ventilatory failure. Treating this scar is not a solution. We ignore a ventilatory problem, hoping that it goes away. The failure of ear surgery is because of ventilatory failure. So good hearing result means there should be an aerated, good aerated middle ear. So endoscopic has a better view in examination of ventilatory pathways. So it is absolutely about the understanding of anatomy and disease process by endoscopy, gaining access to the retrotympanium, enteroatic protympanium to remove the diseases, using ear canal natural orifice as an access point to the middle ear structure. Reduce the need for mastectomy and avoid reduce pain and scar. Endoscopic ear surgery has achieved a better surgical views in access to entire atic supratival recess, sinus tympani, editors ad antrum, and other hidden areas, and views the entire ossicular chain, nations, and magnified views, and good for teaching of residents. The basic goal of endoscopic tympanoplasty is there should be a direct exposure to the tympanic membrane, supports of the graft, good upper left on both sides of the graft, perfect vision of epithelial elevation, angle visions for graft placement, and avoid medializations or lateralization. Our journey for endoscopic ear surgery started from the Telegaon on 2014 in the first international masterclass in endoscopic ear surgery workshop. This is our experience. We have done around 6 cases, of which the 93 are microscopic. Single-handedly, we did 58 cases, and double-handed technique, we did 155 cases. Our endoscopic tympanoplastic procedures are our OT setup. You can see here, setup of a microscope only the optophine microscope we use to attach the endoscope. You can see here, we use the normal micro ear surgery instrument with the stage and few angle instruments. And it is very important to orient our sisters to keep the instrument in serial. There are certain modified instruments like more curved angle pick, more curved round knife for reverse elevation, especially in the anterior elevation, angle curette, modified cobra for denuding handle of malleus. We do not use cotton cloths in instrument tray. We use a plastic. The patient position is always, when the patient is on table, always confirmed the right and left side from the patient itself. And so the supine position, always use the ear draft, saving off the part where the graft is to be harvested, and trim the hair if it is. The initial step, always prepare the ear before surgery. There, if there is a wet ear, we make the ear dry by giving steroid, antibiotic, etc. Then we do the suctioning, watering, cleaning, adrenaline shock, Merosil, clean the canal with betadine solution. And we use a ringer lactate for washing ear canal because it is near to the physiological fluid. We only use Merosil instead of cotton ball because the cotton ball fibers stuck in the field often. we only use merosil. We don't use the cotton chalk adrenaline. We keep the this adrenaline shocked here in between the scaphoid fossa just to save the time. Otherwise, pick from the sister's ball, it takes time. Then scope of the positions, we keep the scope almost in the middle of ear canal in between. The suction tip on the left side of the scope, while the instruments on the right side. The scope preferably rests on the floor, creating the more space for instrumentation.
So the mobility of the camera, this is a camera system. This is the movement is like this. This is to and fro movement. And from inside outside we use this. So you can see that this much of movement we are getting. So this is the movement we get inside. Thank you.
Then infiltration, we need widening view of the canal with press with speculum or with the hands or with the suction tip. We use 2% dialocane with adrenaline infiltration in 4 quadrants. We use 26 gauze needle for infiltration. Try to be as slow and steady to avoid any black formation and avoid too much suctions on the canal while cleaning. Pressing of margin incision should be sufficient margin should be included to include the ingrowth of the epithelial migrations. Use suction control while removing the margin. Avoid injury to the canal while freshening the margin. Elevation of metal flap is very important, especially for the beginners. The canal incisions needs a control with 2 hands. Always maintain the 90-degree with the canal bone with the canal knife. Be on the bone is a slogan. Elevation of the flap needs a suction behind. We use the small suctions like 20 to 21 size. Use small marrow shield to protect the flap injury. Small flaps curves itself, so incision should be put little bit lateral to the perceptions. Means if you feel it okay, you should keep your knife little bit lateral to it because of the endoscopic because endoscope enlarged. So you should keep a little bit lateral so that the flap is not very small. We do the interlay elevations. Interlay elevation means we elevate all around equally till annulus. From there itself, the interlay elevation started. We engage the right angle hook and feel off from the anterior side. Then superior base flap we use because of its thicker and good graft depth, good overlapping, good healing, and good for parking the flap. The advantage of endoscopic interlay elevation, there is no fear of iatrogenic cholesteatoma. Although there is a poor support of mucosal layer, the support from the canal wall is very good. And covered by the fibrous layer and skin, so there is a perfect overlap of both sides of the graft. And there is a less fear of blunting as post-graft and angle lesions help tucking on anterior canal wall. The middle ear work is also very important. We have to clear the ventilative pathway. We use to clear with the ball probe and merosil. We expose the key areas. Always try to look the IS joint, check the ossicular chain, and flush the eustachian tube and key area is very important because sometimes the foreign body loads in the eustachian tube area. Then denuding the handle of malleus is also very important. And it is very difficult with a single hand because it may lead to more mobility of ossicular chain and unduly force. Therefore, we used a modified Cobra instrument for denuding of handle of malleus. And always start from above downward, exposing the lateral process. And if there is a tissue remnant in the tip of the handle of malleus, merosil, it comes easily. Try to see the IS joint. Then sometimes we drill, or sometimes most of the time we use the curette. For curette, curette is good. Grafting is very critical step. Most difficult step with one-handed technique, suction and ball probe control to maneuver the graft precisely. Smaller suction, we use the size of 21. Bed-to-bed grafting, we use the temporal fascia, mostly interleg grafting. Size of the graft is almost thumb size, and we lay the graft on the bone 360 degrees. No gel foam is used in the middle ear. Kind of a foreign body. We try to put air in the middle ear, supported by antibiotic soaked gel foam. Earwig in case of tracheal cartilage if harvested. Sometimes we applied mustard bandage if hematoma is suspected. Post-operative management, we discharge on the next day with fake removal on 12 to 14 day. Ear drops we started at fourth day after fake removal from 1 month. Removal at review at 1 month. Audiometry we repeat 3 months. So basically, we do two-handed endoscopic tympanoplasty. So we strongly advocate for the technique. So basically, endoscopic ear surgery is done by single hand, and why there is need to be changed in already existing technique. Still, we can do so many things with one hand, but we need two hands to perform it in easier way. The reason for starting a single hand endoscopic ear surgery is basically non-availability of endoscope holder freely in India, and no training avenue for young surgeons, no teaching program of two-handed technique in PG curriculum. Disadvantage of single-handed technique: one-hand surgery, naturally there will be a natural handicap. No suction in other hand. When bleeding starts, it can frustrate the surgeon. Blood placement is very difficult with one hand. Left hand fatigue for holding the endoscope could be there. Advantage of single-handed is it can easily adjust it with working distance. Left hand can go along with the right hand easily, maintaining a required image. And it creates the cinematographic effect also. So may recommend for examination of middle ear hidden areas. The rationale of two-handed endoscopic ear surgery is basically a two-handed technique, whether it is any method, microscope or endoscope. It needs a fine, gentle, and controlled movements. Our right hand and left hand complementary to each other, making ear surgery in a convenient way. Examination of the and cleaning of ear. Here also we need suctioning, watering, grasping together can possible only with two hands. Infiltrations also need certain, we need the view of canal wide press either with speculum or with hand. Here also we need two hands. Even for pressing of margin, incision around margin may not require two hands, but while removing it in total, suction control gives a better removal. For beginners, canal incision needs control. Bleeding make it worse, especially while elevating. Middle ear work also, precise middle work needs two hands. For inspection to the middle ear ventilative pathway, we can use angled scope with two hands. Denuding of handle of Melius also very difficult with single hand. More mobility of ossicular chain and unduly force may be exerted. Precise ossiculoplasty require two hands. If we do TAE, the counter traction is also required for precise cutting. Total annulus excision we usually do here. Cholestoma, even for cholestoma work, and drilling is two-hand work. Even for good curates needs two-handed control. Elevation of cholestoma in a single check from the mucosa needs two-hand work. Grafting also the most difficult hand technique. Dry graft is better with one-handed. Suction and ball probe control to maneuver the graft precisely, which can be easily done with two hands. We use wet graft, especially temporal fascia. Endoholder is a solution for two-handed ear surgery. We have a pioneer in this field, Justice by Mubarak Khan from the Pune, and Endo is a holder by our own member and our senior and moderator of today's session, Dr. Anupam Hajrika. Justice by Dr. Mubarak Khan, we are in our center. We attest this in the microscope, except in J's microscope. There is a to and fro, side to side rotating movement around the vertical axis, and improved versions also available. This is just Justice by Mubarak Khan. First, we used Justice ASM1, but it was not very good, so we used Justice ASM2 now. So Justice ASM1 was not microscope, and it was very difficult, and so we had to shift to the microscope actually because of difficulty. But later on, we got a new one, then we shifted back to endoscopic ear surgery. So our the ASM1 is a basic model, but it's handy but not compatible with all. Difficult to fix in microscope. So ASM2 is better. It's handy, easy to fix. Right hand, left hand fixation option is present. Wide range of movement with more space away from the microscope. Free hand movements. This is the improved version. Sometimes microscope arms lose it and fall down. Endoscope if hit the patients and damage. This is one endoscope in our case, it fall down. But fortunately, it doesn't hit the patient. If the patient moves head suddenly, we may injure the miliary structures because there is a less time to withdraw the scope in case of two-handed technique. There is a disadvantage of two-handed. Heat generation is one area since it is fixed inside. So for that, we need to do the continuous irrigations, and the light source we have to keep less than 50%. And difficult to see the hidden area. See the hidden area, we scope and single-handed. And the learning curve is a slow learning curve. Keep doing the case, and good case selection is required. And we required more instrument in already overcrowding hospital, like OT, like monitor, microscope, endoholder, etc. So how to start with two-handed technique? If one being already single-handed endoscopic ear surgery, get endoholder and just start two-handed. If not doing endoscopic ear surgery, then attend the course of two-handed endoscopic ear surgery. Case selection is very important to start with. Wide canal, male, dry ear, non-hairy. Teenage is less. Teenage is less. Ear canal is a little bit narrow, so it will be difficult. And we should rule out the blood pressure, high blood pressure. The first case, left, if it is left ear or right-handed person should be. Always start with 0-degree endoscope. Initially, do a transcanal ear examination, etc. And when you do microscope, teach on to the endoscope before reaching annulus, just for beginners. As you gain experience, do less with microscope and more with endoscope using holder. This is our technique.
Hi, I'm Dr. Jigo Ori from Itanagar, Arunachal Pradesh, India. Here we are going to see a two-handed endoscopic interlap tympanoplasty. This is a pressing of margin of the perforation. Make sure that a sufficient margin of the perforation is to be included to remove the epithelial migration and remove the margin with a grasper. And denude the tip of handle of malleus before elevation of the cleft. And this is our incision. We follow 240-degree incision and 360-degree elevation. Make sure that the knife is placed on the bone at almost 90 degree. And elevation should be...
Jago, have you optimized the video? It's not coming nicely. Do you need to
engage like this, and then peel it off. Peel it off like that, and then peel it off all around.
Coming.
This is the key step in tympanoplasty interlay elevation.
Jago?
Ah, yes.
The video is not coming.
Oh,
And then denuding
Jago,
the handle of
Jago,
Melee,
yes, yes.
we follow
Jago,
from
Yes.
Your
above
video is coming,
downward.
but your video is not coming.
Jago, the video is not coming. Your video is not being played. If you could optimize the video and share the video, share screen again.
Okay, okay, okay.
Just start with the video.
Okay, okay. Now it's coming.
Still not.
Okay, okay. Let me try.
Hi, I'm Dr. Jigo Ori from Itanagar, Arunachal Pradesh, India. Here we are going to see a two-handed
Here, now coming.
endoscopic
No.
tympanoplasty.
Your voice is coming, but video is not coming.
Pressing of margin of perforation. Make
Jigo,
sure
when you stop the
sufficient
video, you
margin
stop the
is
stops.
included.
Jigo,
Okay.
you stop
Jago.
slide sharing.
Okay.
Probably your video is working in your computer.
Yes, yes, it's working.
Yeah, you stop sharing your presentation.
Mm-hmm. Yes.
Stop your
Then,
presentation.
Stop your presentation.
Mm-hmm.
Sharing
Still,
you stop.
Okay.
Yes.
Then you
Optimize
do
the
one
video.
thing. Then again, click the slide share screen.
Mm-hmm.
Then one screen will come. That there you will find your video.
Yes. Uh-huh.
Click there and share.
Double click. Nah?
Yeah, you clicked. Yes.
Okay, okay. Now,
No, again your presentation. Yes. Yes. Now, yes.
Now you
Remove
click.
the epidermal migration.
You need to optimize
Hi,
the
I'm Dr.
video first
Ori
and then share.
from Arunachal Pradesh,
yes,
India.
optimize.
Here we are going to
Optimize
see
and then share.
endoscopic interlay tympanoplasty.
No, still not. Yeah,
This is the
it
pressing
is
of
coming.
margin
Yeah,
of
it's coming.
perforation. Make sure that a sufficient margin of the perforation is to be included to remove the epithelial migration and remove the margin with a grasper.
Is it coming?
And you need the tip
Yes,
of handle
yes,
of
it's
the
coming.
before elevation of the cleft. And this is incision, our incision. We follow 240-degree incision and 360-degree elevation. Make sure that the knife is placed on the bone at almost 90 degree. And the elevation should be equally all around and gently till the level of annulus. So annulus is seen, we engaged a 90-degree hook, engage like this, and then peel it off. Peel it off like that,
Lola,
and then
কিমান পৰিলে দাম?
peel it off all around. This
ঠিকে
is the
আছে।
key step in tympanoplasty.
এইটো সেই ৰহিদৰটো দিছে। কাৰিকৰটো দাম বেছি আছে। ঠিক আছে হ'ব। ঘূৰি আহা।
And then denuding the handle of malleus. We follow from above downward. Like that, you can see there should not be any mucosa in the handle of malleus. Then the area anterior to the handle of malleus is to be cleared off. There should not be any mucosa there. And we check the ventilative pathways and ossicular chain. Here, ossicular chain is intact. We can see the round window reflex. Then we reposition and see, and then we remove the edematous tympanic membrane. Total annulus excision is a game changer. Total annulus excision is a new concept. We've been doing it in almost all cases. we use iris scissor with a suction control. We can cut it. That is the Merocell is placed in the posterior isthmus and clear all those debris, and then we flush with water in that key areas. Always try to flush water in the institution tube area and that key area. And then try to clear with Merocell the posterior ventilatory pathway also. That way, the all three ventilatory pathway is clean. And then we, with reverse elevation anteriorly, and this is the annulus being excised in the anterior part. Here also similar procedure, we use iris scissor with the suction control, and then reposition and see the position of the pleth. And then we removed the mucosal tag, which is edematous from the anterior side. We cut it off because this mucosa may hamper the healing process. And then we do bed-to-bed grafting. We harvest the temporalis fascia at the last part of the surgery, and this is a wet grafting. And it is easy to maneuver with the ball probe and the suction control. Make sure that the edge of the graft is anchored all around 360 degree. And every edge of the graft should be checked again and again. So we are just trying to anchor all around anteriorly and then posteriorly. And then the pleth is repositioned back while placing the pleth back. We have to be careful and try to see back again if the margin has been dropped or not. Just we're trying to lift the margin of the graft posteriorly. And we must ensure that the graft should be placed all around 360 degree and margins should come off. Here we are checking anteriorly. See, there is already the graft has been fallen down. So that is the importance of checking it again and again. And then the flap is placed back. Make sure that the graft and the flap is kissed each other properly. So that's how we trying to make the union of both graft and the flap. This is the last step. So with circular knife, we try to reposition the graft and the flap. And then lastly, we put a gel foam all around, soaked with antibiotic. Thank you. Thanks for watching.
Dr. Chigo, please unmute yourself. Yeah, you can start sharing your original presentation.
Is it coming, Mana?
Yes,
Yeah,
yes,
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 coming.
coming.
This slide is taken from the Anupam sir slide. Dogmatism is the end of science. Approach should be selected to demand of anatomy and laws. Techniques should be tailored to comfort of surgeon and his expertise level. The absolute one technique or approach may negatively affect both surgeon and patient. So to conclude, the endoscopic tympanoplasty is a procedure. Two-handed endoscopic surgery is emerging technique. Exclusive double-handed or single-handed is a dogmatism. Mastering both technique has an advantages. Both middle ear and mastoid can be built with endoscope. In case of bleeding and counter needs a patience. Beginners should start with two-handed endoscopy. Future of endotympano will depend on the endoscopic technique, residents and fellows, prospective studies, instrument development, safety studies, education, surgical course or sector, training on endoscopic ear surgery simulator on the fresh human temporal bone. And it is very important to strengthening the nails. More workshop on endoscopic surgery is needed in India to popularize the technique of endoscopic ear surgery. Our ultimate goal is to cure disease. So let's always help each other. Thank you very much. Thank you.
Thank you, Diego, for your comprehensive presentation on endoscopic tympanoplasty. There you have nicely touched on important aspects of the surgery. A few things which I feel you could have shared is like you have, could you please speak on the preoperative evaluation as to what special precautions you would like to take up before considering the patient for endoscopic tympanoplasty, and whether you just consider tympanoplasty as being a procedure to patch up the puncture, or you elaborate further whether you need to work on the total ventilation pathway starting from the isthmi to the editus, because editus patens is an important aspect of tympanoplasty procedure.
Yes, sir. Yes, sir. Yeah, whether to go for endoscope or
Diego,
yes, sir. Yes, ma'am.
you stop sharing.
Okay.
Now you discuss.
Okay. Yes, sir. It's a very important pre-operative evaluations of the patient, whether the patients need to be undergo endoscopic approach or a macroscopic approach. The first, what we try to see is, as per tympanoplasty is concerned, we try to make the ear dry. So first we see we don't take much on dry ear. The wet ear. Try to make the ear dry, and then first we try to examine the canal. If the canal is very narrow, then we better go for macroscope. And then ventilatory pathways are irrespective of any whether it is endoscopic or C. Just patching the hole, the preparation is not a solution, as I've already mentioned. We have to clear the three ventilatory pathways, technique SMAS and posterior ventilatory pathway and anterior ventilatory pathways. These three, we must clear it. And before surgery, basically we see whether we see the middle ear mucosa and whether it is a good looking mucosa or not. So like that we evaluate. And then we decide the approach. If it is a very extensive cholesteatoma, look like a very extensive cholesteatoma and all, then we might go for the macroscopes.
Yeah, exactly. So we keep our approach an open-minded one. If we are dealing with a cholesteatoma disease, probably we will not keep our limitations confined to the endoscopic way of approach. So we shall keep it open and go as the disease demands. So by doing a preoperative CT scan, probably you will have a better preparation of the case, whether you should do a primary microscopic and endoscopic adjunct, or you should go with a primary transcanal procedure beforehand, so that this is going to save a good lot of time.
Yes, sir. Yes, sir.
Okay, we have a question here from Apurva, Dr. Apurva Sharma sir here. Dr. Apurva Sharma has put, what are the limitations of S? So we have already discussed on that technique, like two-handed technique has been, the single-handed issue has been the biggest limitation of in the last 3 decades. And fortunately, the Indians have pioneered on the solution to bring an solution into this issue of single hand issue, because in the first World Congress, it's from India that 2 solutions were presented there. And today, as we see, even pioneers of this technique itself, Levio Prisuti, they have in Italy have designed endo holder for dual hand technique. So that is one single, I think, is the biggest limitation that as has ever faced.
Yeah, I think if we do endoscopy two-handed, limitations are very less actually.
We have another question from SB Fukan sir, like when we go for an open case, which technique is more favorable, endoscopic or microscopic, when you like to deal with the mastoid, open cavity mastoid surgery? Jago, you'd like to take on that?
What is the question, sir? Come again.
In open mastoid surgery,
Uh-huh.
what technique you would prefer as a primary procedure, whether it is an endoscopic or a microscopic approach first?
Yeah, in that case, I think people are doing with primary endoscope also, but I think it's better to go for a microscope.
Yeah, like it's see, in the previous days when prior to the era of laparoscopic abdominal procedures, when we used to have open abdominal procedures, laparoscopy always had its appreciation and beauty of doing it, but it had its own limitations at some point of time. Now, when we are dealing with an extensive disease, probably I think the best way is to keep an open mind, and
Yes.
wherever possible, we should go with a combined approach so that we can try or give our best effort to preserve the normal anatomy, at least the posterior superior canal wall, if we can preserve by with a combined approach, because with the angle telescopes we can see from behind as well as from the transcanal approach. Thereby, if we prevent the normal anatomy and try to preserve to the near normal state, probably we'll be able to achieve a near normal physiology of the middle cleft. Mukherjee sir has commented on the Wilson's test for eustachian tube patency is done preoperatively. Jago, would like to comment on that?
No, sir. Please, I don't have. We don't have.
Eustachian tube patency as a factor determining the outcome of tympanoplasty procedure is more of a theoretical concept, because it is the tympanomastoid environment which basically is responsible for successful outcomes in tympanoplasty. The physiological patency of the eustachian tube and the anatomical patency both has a difference in its role in determining the surgical outcome. It is actually the middle gas exchange, middle ventilation pathways which actually determines the outcome of the tympanoplasty procedures. And that's how endoscope has helped in a better way to deal with this endoscope, this middle ventilation pathways, establishing it, re-establishing it, clearing the blocks, and thereby making pathway for circulation within the tympanomastoid cavity. We have how long to keep the ear pack from Dr. Kripamoy Nath. What antibiotic mix packs given in your series? Can we do canal wall down mastoidectomy using endoscope? If yes, then kindly explain. Jago?
Yes, PEC, we usually we put antibiotic. This packing actually we put gel form only. That gel form PEC. We don't put extra packing like that. We just put betadine soaked gauze just over that's all. And then we keep it for at least for 12 to 14 days. Then we removed on 12 to 14 days. And sir?
And what is the preparation of the antibiotic that you use?
Ofloxacin, sir. Ofloxacin.
Only ofloxacin. Have you noticed any kind of opportunistic fungal infection during that phase? If you're using pure and this antibacterial component antibiotic?
No, not yet, sir.
Yeah, but there is always a possibility that if you use pure without antifungal component, there's a possibility that the opportunistic fungal infection may take place sometimes. So it's always better to use a mixed preparation.
Okay.
And the second part, can we do canal wall down mastoidectomy using the endoscope? If yes, then explain. Would you like to take on that?
No, I don't think so. Basically, the canal wall down. Actually, basically why endoscope is required. It is actually to prevent try to avoid address the disease without canal wall down actually. So if we have to do canal wall down, I think better go for the microscope.
Yeah, actually endoscope never came to replace the microscope. That is a wrong concept that has been going for 2 decades almost. It is basically a tool that needs to be exploited by every otologist in every way possible. And yes, there is one technique, what you call it, exoscopic endoscopic. That is, we use a 10 mm endoscope to do the similar kind of a canal wall down procedure, just as the way we do with microscope. But basically, I think it's not about replacing the microscope to do a canal wall down procedure.
And most of the cases, cholesteatoma cases, most of the cases can do it in endoscope only. So no need to go down for
yeah, depending on the extent. If it is stage 3, better we go with the combined approach.
Yes.
We have one question from Dr. Biplab Nath. Is the hearing improvement better with interlay?
I don't know. There is no comparative study. Because it gives more physiological way of grafting. Definitely, there should be improvement in hearing, but we need to do a comparative study actually, whether the certain grafting way, interlay, overlay, or underlay gives a different hearing result or not.
We cannot exactly comment on the better hearing improvement with interlay as such, but of course we can comment on that the graph uptake rate is better with interlay. We have a question from Sanchita Kalita. Sanchita has put on a question. What is the advantage of total annulus excision? Yeah, Jago, your take on that.
Yeah, total annulus excision. What we are doing is if we first of all what it is, if we remove the annulus totally, we have to, so the vascularity of the vascularity of that the tympanic membranes, since we have incised all around, the vascularity is open up all around. So it gives more vascularity to the nutrition to the tympanic to the graft. That is one advantage. And another is like if we want to remove the annulus, there is a frequent hanging of annulus when you put it back. If we remove the annulus, if we elevate the annulus, because usually we elevate the annulus in all technique. So when it put it back, it doesn't put it as like a physiological. So it usually hang over just over it, and then sometimes it's the healing process. So that is one hanging annulus. Some of the time, if you see after post-operative, your annulus is just lying laterally sometimes. So we could put it back properly. So better we remove it all around, and then there will be good appositions of the flap over the graft. That
yeah, Anand, but we have been doing this total annulus section in few of our cases since last around 3 years. But what is practically seen is that total annulus excision done in all cases is an overdone procedure. And once we take off the annulus from the bony sulcus, the physiological role that the annulus actually plays does not remain physiological to the extent in the postoperative period. However, the basic concept behind doing a total annulus excision is that in cases where we see perforations to the extent of subtotal, where the epithelial ingrowth is a possibility, in
Yes.
those patients, I think total annulus excision is the justified procedure. Otherwise, it's an overdone procedure for each and every case. We have one question from we have a comment from Kripamoynath, Dr. Kripamoynath, about the interlay elevation of your video, which you missed out. Probably we'll have a better time to show this interlay tympanoplasty again. And we have another question from Satya Brota Fuk, as we focus here. Is depth a big issue in endoscope than microscope? Diego?
No, there is no big issue. It is, I think, just a matter of what you have chosen and what you have trained. But I think being, in the era of development and progress, like since the everything is being progressed, the surgery also is evolving. So we have to. It is not like which one is to be discarded or which one to be adopted, but it is just a changing procedure, changing process, and evolving. So whatever the surgeon is adopting, making a difference in the result, I think that is more important. So endoscope as such has got so many advantages in basic procedures like tympanoplasty. This type of regular procedures, it has definitely have edge on the microscope. That is what I feel.
Yeah, actually, this fisheye effect, the depth perception, these are all integral aspects of endoscopic procedure. The optics itself is like that. So just the way we have learned to train ourselves while doing endoscopic sinus surgery, using the endoscope, getting into the sinus, and even reaching the anterior skull base, I think the depth is not a major issue even in endoscopic otologic procedures. And it's just a matter of time. And with the development of technology, as we have seen, 3D technology has come in. So that is another way by which the depth issue can still be, become a null and void issue in future course of time. But what I personally feel is that it's just a matter of time that if one keeps on doing, the depth perception comes on easily. We have the last question from Dr. Kripamoynath here. How to defog the endoscope during surgery?
How to?
Defog the endoscope during surgery.
Oh yeah, during surgery, especially when we do the double-handed, the heat generation is also there. So one thing is we put the water actually intermittently. That is one way to defog it, and other way is to lower the temperature, heat generated from the tip of the scope. So otherwise, we use the normal Savlon just for defogging, but most of the time we put water only.
Yeah, and another thing is while doing a two-handed technique, the endoscope, on the other hand, also adds to the defogging effect. So that is another advantage that we get with an suction in the other hand while doing a two-handed technique.
Yes, yes.
So that's all we have from showing us the question in the chat box. So thank you, Diego. We have come to the almost reaching an end of time of the session. And thank you everyone for being there in this presentation today. And lastly, I hand over the session to the Dr. Apurva Kumar Sharma for conclusion.
Jana?
Yes.
Yes, you conclude the session.
Thank you, Dr. So I have to mute everyone again. Okay. Thank you, Dr. Jigo Ori, for your wonderful presentation, and Dr. Anupam for moderating the session nicely. And it was a fruitful discussion, and everyone participated in the discussion. So my thanks goes to all the participants. And I just wanted to tell you that today will be the last last NEBOI classroom, but we'll be having third session again in the month of January. This decision has been taken by our NEBOI executive body. Please accept it. We'll be meeting soon in the month of January also, January. So for the time being, let's close the session and over to Fauziya Baidu.
Thank you all the participants. So we'll meet again in the month of January with little different academics. Thank you very much.